Hello, thank you for joining us tonight, and thank you to the unions that are hosting tonight's event. The American Federation of State, County, and Municipal Employees, the American Federation of Teachers, the National Education Association, and the Service Employees International Union. My name is David Michaels. I'm the moderator for tonight's town hall event. I'm an epidemiologist and a professor at the George Washington University School of Public Health. I was Assistant Secretary of Labor for OSHA. I ran the Occupational Safety and Health Administration for President Obama. Welcome to the thousands of union members and leaders watching this event. And special thanks to the union presidents who helped put on this event and who are on the line with us tonight. Lee Saunders of AFSCME, Randy Weingarten of AFT, Becky Pringle of NEA, and Mary Kay Henry of SEIU. And thanks to all the other national and local union leaders who have joined us in this very important town hall meeting. Lee Saunders wanted me to let everyone know he received his first COVID shot today, and he's feeling fine. He reports no ill effects, and he is very much looking forward to shot number 2. So together, your over 8 million members have been on the front lines caring for our sick and for our elderly, teaching and supporting our nation's students, and keeping our communities functioning and keeping them safe. Thank you. The entire country is grateful for your service and for your commitment. All of your unions have members who have cared for those with COVID-19, have seen family members sickened and have gotten sick themselves and tragically have died in many cases. This vaccine could have incredible consequences for many of you at this event and for members of your union, for members of your family. And many of you fall into the early categories of distribution. You'll be in the front of the line, and that's why we're here tonight, to talk about that. My whole life has been dedicated to ensuring the health and safety of the women and men that support the American economy and putting public health first for them. I'm currently a member of the Biden-Harris Transition COVID Advisory Board, and that's why I'm very pleased to be joining you this evening for this important conversation about COVID-19 vaccines and to answer your questions. So with a handful of COVID vaccines now authorized for use and more in the pipeline, it is an important time for transparency and a critical time for understanding not only the development process for these vaccines, but also safety, efficacy, and equitable distribution of the vaccines to make sure it's done fairly. Each and every one of us will need to make our own individual decisions regarding vaccination based on the best available evidence. We all know how important it is right now to be sharing information and answering questions around recent developments, approval, and the allocation of the COVID vaccine. And as you know, this is changing on a daily basis. So tonight's virtual town hall event is an opportunity for you to hear directly and to have a dialogue with some of the leading experts on COVID-19 vaccine, 3 people who are playing a major role in the nation's vaccine program. Let me just introduce them together briefly, and then we'll go to each one of them. First, Dr. Peter Marks. Dr. Marks is director of the Center for Biologics Evaluation and Research at the Food and Drug Administration, the FDA. So he runs the agency responsible for reviewing the safety and efficacy of COVID-19 vaccine candidates, the ones that are being considered. And the vaccine is not authorized until Dr. Marks signs off on it. Second, we'll have Dr. Nancy Messonnier. And Dr. Messonnier is the director of the National Center for Immunization and Respiratory Disease of the Centers for Disease Control and Prevention, or the CDC. So her agency is involved in efforts to prioritize which groups should receive the COVID-19 vaccine when and in what order. And also they're responsible for coordinating with states and local public health authorities on the distribution of the vaccine and how it's going to be done. And then we have Dr. Helene Gayle, who is the president and CEO of the Chicago Community Trust. Dr. Gayle is a renowned infectious disease specialist and a very respected voice on healthcare equity issues. Dr. Gayle served as co-chair of the Committee on Equitable Allocation of Vaccine for the Novel Coronavirus. It's a long name for a very important study panel at the National Academies of Sciences, Engineering, and Medicine that made recommendations on who should get the vaccine, in what order, and how it should be distributed. So thank you all for being here tonight. I think what we'll do now is give each speaker a time for short remarks, and then we're going to go to the many questions that you submitted. So first, let's go to Dr. Marks, who will share a brief background on the FDA review process, essentially what went through for the Pfizer, the Moderna vaccine, and other ones that are coming through. And that includes clinical trials and really what the FDA looks at in terms of safety and efficacy before authorizing a vaccine. So Dr. Marks.
So thanks very much for having me tonight, and thanks for taking the time to join. So FDA's role in development here is we actually take these products essentially from beginning right through approval or authorization, and out then working with the Centers for Disease Control and Prevention on the post-marketing monitoring. So for these COVID-19 vaccines that were authorized, this was quite a remarkable achievement of moving things forward relatively quickly. Candidate vaccines went into clinical trials. Those clinical trials were done relatively seamlessly, moving from phase 1, 2 into 3 in very quick time, without space in between them. At the same time, the manufacturers were working on the process needed to make the vaccines in larger quantities, so that they would be available if the trials were successful. While all of this was going on, we were having a dialogue with the companies, so we understood what they were doing. And as they got towards the end of their very large trials, we were able to then take the results, analyze them, and feel comfortable that what had been done met our standards. Now, part of the reason why that was possible was because during this time, we had given the companies guidance, which is actually a formal thing that FDA can do, and that helped, so that by the time the Pfizer vaccine was submitted to us, and then the Moderna vaccine was submitted to us in December, we were able to have these authorizations called emergency use authorizations about 1 week apart. Now, an emergency use authorization isn't a full approval, but for these vaccines, they are pretty close to it, because we were able to review the data on the effectiveness of the vaccines and on the safety of the vaccines. And in terms of efficacy, they met a clear efficacy endpoint. And as you may have heard by now, they're about 95% effective across the entire age range from 18 on up into people who are in the older age population. They were equally as effective in a variety of different ethnic backgrounds, racial backgrounds, including the Black African-American communities and the Latinx communities. So these, for both of these vaccines, were pretty impressive as they came through. The safety profile was such that we felt comfortable with them. The one piece that we're a little bit short on for these vaccines was the normal length of follow-up, which we would have, which would normally be somewhere on the order of somewhere 6 months to a year. But we're making up for that by working with our colleagues at Centers for Disease Control and Prevention by doing a combination of both active and passive safety surveillance, so that we will understand if there are any problems that arise. And I'm sure we can talk more about that with questions that may come up later. But I'll just say that the end result of our process, which was somewhat of a public process, we had a public advisory committee for each of these vaccines, and all of the documents, the major documents, are posted on the website that went into the advisory committee meetings, and then that reflect the FDA's thinking are posted publicly. That process, I think, has led us to feel very comfortable with recommending these vaccines at this point. And they make us comfortable enough that we're willing to feel comfortable enough. We're willing to take them. We're willing to recommend that others take them. So I'll stop there.
Great. Thank you so much, Dr. Marks. So next, I'm pleased to welcome Dr. Nancy Messonnier, and she'll share an overview of the process taking place to distribute these vaccines and how CDC is working with providers and with partners to communicate information about the vaccine. So Dr. Messonnier.
Thank you, and thanks for the opportunity to speak to you again today. I will definitely keep my comments hopefully short because I know you all have lots of questions. And frankly, that's also part of our job. All of our job is to answer your questions. So I want to start sort of where Peter stopped a little bit. So as Dr. Mark said, FDA had issued an emergency use authorization. Their advisory committee made that recommendation to them. The next part of that process routinely is that it comes to CDC, where our advisory committee on immunization practices has two roles. One role is to make a recommendation for use of the vaccine, and that happens with any vaccines that are used in the United States. And it's done in plain air, just like the FDA advisory committee. So you can actually see the inner workings of the committee, and you can hear the discussions. They review the safety and effectiveness data, and it's really a check and balance to make sure that we are utmost careful before we make a recommendation. But for this vaccine, there was an added responsibility of ACIP. We anticipated that in the early days of the rollout of this vaccine, the demand for the vaccine would outstrip the supply. That is, in the early days, there wouldn't be enough vaccine for everybody who wanted it to get it. Now, we have anticipated this, frankly, all year, and that's why the National Academy also had been looking at a framework for recommendations around prioritization. The World Health Organization and Johns Hopkins all looked at this. ACIP took all their recommendations together and came up with what we call a framework to say, if you have limited doses of vaccines, where do you start? And this is provided to health departments to help them sort of figure out how to target their early efforts. And so those in the first group were frontline healthcare workers and residents and staff of long-term care facilities. But then ACIP said we should go on from those groups to the next groups, which are essential workers and those at higher risk because of their age. And that was divided into two phases, phase 1B and 1C. And I think it's perhaps been a little misinterpreted that those phases were meant to be barriers. You have to finish everybody in phase 1 before you get to phase 2. And in fact, that really wasn't how it was meant. It was just meant to kind of give a framework as a starting place, because otherwise, if you turn the tap on right away too much, the people that we think are at highest risk or in most of need of vaccination might have ended up at the back of the line. So this is an attempt to try to make sure that, that folks get to the front of the line if they need to, and that includes people who are at higher risk because of their age, but also essential workers like you all, whose jobs put you in the front lines and whose jobs require that you come in contact with the public, but also whose jobs make you essential to the rest of society's functioning. And so that's how those frameworks were put together. Our advisory committee, even before they actually made the recommendations, had a number of principles that they published. And one of them was to make sure that equity was front and center in their deliberations. And that also really did impact how those recommendations were made. But our desire is for those frameworks to be efficient, effective, but also flexible and responsive. And in some communities right now, in those people that were at the highest risk, in fact, there isn't a lot of demand. And so many jurisdictions are moving on to other populations. We work directly with local and state health departments to help them basically figure out how to roll out the vaccine to keep with these principles. And I would say in general, our approach is that vaccines should go to every corner of the United States. But equally, we need to make sure that people are getting the information and education they need so that when it's their turn to get vaccinated, they're ready to roll up their sleeves and get the vaccine in their arm. And also that when people aren't ready today to get vaccinated because they don't feel like they have enough information or they're uncertain and they get passed by, we need to come back for them. There shouldn't be anybody left behind, and there should be multiple ways in which people who today might be might be prioritized, but sort of aren't so sure, don't feel like if next week they feel ready to get vaccinated, you should be able to go back and get your vaccine then. So I will stop there. I will also just say that it hasn't been my turn yet, but when it is my turn, I will roll up my sleeve and get vaccinated. My parents are in their 80s. They are on the list of people to be prioritized. They've registered to get vaccinated, and frankly, they and I are anxiously awaiting their turn. And I made them promise to take pictures for me when they get their vaccines. So I thank you again for everything you all have done this year to make it possible for the rest of our societies to function. And I certainly look forward to your questions.
Thank you so much, Dr. Messonnier. So our next speaker, I'm very pleased to welcome to the conversation Dr. Helene Gayle. Dr. Gayle, can you speak to what's needed to be able to offer the vaccine to communities that have been long overlooked and underserved by our healthcare system, as well as what needs to be done to educate the public and healthcare professionals to meet these needs? Dr. Gayle.
Yeah, great, thank you. And maybe I will just step back for a minute and say a word about the framework that we helped to put together that was foundational, I think, to some of the work of the ACIP, because it relates to the question of, particularly communities that have been disproportionately impacted. And so, as you mentioned, we put together this study this summer that was done kind of before we knew a lot of the things that we frozen for a minute. The National Academy of Science, Engineering, and Medicine, an independent body that does reports to focus on issues of key social and health issues, was asked by CDC and NIH to put together this framework. And I think Dr. Messonnier has talked a lot about the ACIP recommendations that are very specific once there's a vaccine to CDC to really talk about how it can roll out. And what we did was to kind of, back in the time before we knew a lot of what we know today, help to develop a framework so that the ACIP and other policymakers weren't starting from scratch. Given the urgency of this and given the importance of being able to really start getting vaccines rolled out as soon as we have them available. So this was kind of a chance to set an overarching framework. And I think some of the things that we considered as we were developing this were how this was a unique pandemic that had not only had a huge public health impact, but a huge societal impact. You know, it's the first time in any of our lifetimes that we've seen a public health crisis that has literally shut down our economy, not only here, but around the world. And so we took into consideration both the health consequences, but also the societal benefit and the societal risk that this pandemic posed, and really put together a framework that considered both the health as well as how do we think about how we get society back, what's the maximum benefit that can be created, and put together the risk framework that a lot of people have used in a variety of different ways. And Dr. Messonnier talked about that in more detail. So, you know, I think coming out of that, some of the things that we felt very strongly needed to be emphasized in terms of recommendations, first of all, building on the infrastructure that existed. You know, for decades, we have a vaccine infrastructure that has worked. There's still more to learn, but it was important that resources and attention be paid to building on the existing infrastructure. Also, a recommendation around cost. How do we make sure that, having spent billions of dollars on developing a vaccine, that we also, that cost would not be a barrier to anybody getting this vaccine? So really, you know, not just the cost of the vaccine, but how do we make sure that the administration also gets funded, that the state and local health departments that are so critical to making this happen were also taken into consideration. We also, because this issue of hesitancy and why people, the concerns, particularly back then, before we had an actual vaccine, the concerns about the speed of the development of the vaccine, not knowing a lot about safety, making sure that we gave specific recommendations around how to address this issue of hesitancy. You know, first and foremost, getting the information out there and getting it out at a national level so everybody is hearing the same thing at the same time, and there's transparency about the process of how vaccines were developed, what we know about side effects, and all the issues that the others have talked about. And that in addition to a national campaign, given the impact that it has had on diverse populations, including populations that have a historical mistrust of our health system for good reasons, because of the ways in which populations, particularly communities of color, have been treated within our health system, that it was important that we also worked with community-based organizations, developing messages that were relevant to diverse communities, and that we had messengers who could give those messages in ways that were credible. And that, you know, as we've talked about, people see people taking the vaccine, people who they trust and who they believe in. And so, you know, a lot of focus on how do we make sure that the outreach to the communities that are most hard hit was a part of this. And so, you know, to directly answer your question, I would just say, you know, I think this issue of how we make sure that the messages as well as the messengers are the right ones, and that we're thinking about accessibility in ways that are relevant to communities that may be harder to reach and more hard hit and more likely to be skeptical, and that we're keeping these issues in mind all along the way. As you, I'll just end by saying, you know, one of the things that we embedded in the framework was the use of CDC's Social Vulnerability Index. And this is an index of 15, 17, I'm forgetting, different factors that look at people's social vulnerability, the things that put people at greatest risk, the things that make it more likely that people will not have access to health services. It looks at race, ethnicity, income, household composition, et cetera. And we said that across all of the phases, there should be prioritization to those census tracts that were high on the social vulnerability scale, so that we make sure that those communities got prioritized even across all of the different phases. So I will just stop there and look forward to questions.
Great. Thank you so much, Dr. Gale. So as many of you know, this is the second in a series of town hall events, and I think probably some of you attended the first one as well. I'd like to start where we left off that last one, which is by asking everyone on the panel what they will do when they are offered the COVID-19 vaccine. Now, Dr. Messonnier has enthusiastically already answered that question, but let me ask Dr. Marks first.
Roll up our arms.
That's right. Dr. Gale, you're ready.
I mean, the temptation, it's been hard actually not to try to cheat and cut the line. That's been the hardest part here. And I have not received it yet, just because I don't want to do anything other than do this at the right time with the age appropriate and health associated group that I'm supposed to be with. So when that time comes, though, I'm going to be moving very quickly.
That's great. I feel the same way. So let's get to your questions, which cover just this wide variety of issues about development, safety, efficacy, and the equitable distribution of vaccines.
David, could I say one thing just to follow on that? This is just an anecdotal proof point, but my very best friend, who is like me, a pediatrician and works in the clinical research industry, 2 months ago was still saying she wasn't sure if she would take the vaccine. In the last couple of days, she is eagerly waiting her turn to get there. And that's just a example of, I think, how far we've come, that some of the people who were perhaps the most hardened around this have, as more information has come out, as it becomes clearer and clearer how big the benefit is, I think that, skepticism is hopefully dropping away as, more data points exist. So.
No, that's a really important point, and I think everybody's reporting that. It's a very good development. So I have questions, and I'll name a person to answer them, but I think all three of you, the experts that you are, should feel free to weigh in as well. We are so fortunate to have all all three of you on this panel. So the first questions that come from some AFSCME members, and Dr. Marks maybe can start, but others can address this, is first, you talked about the speed, but what is warp speed? People will ask about that. And did the vaccines go through the full clinical trial process? And did that process represent people of color in addition to white volunteers?
So first of all, warp speed was an idiotic name that was given to this program by somebody who was just looking to put some name on it, since we had to talk about what we were doing. I can say that because I helped provide the name. So it was just there as a name. But let's just take the name aside. The point to this was to not cut corners and to have a vaccine that was every bit the way we would normally expect it to be. And the way that you could say, well, how could that possibly be done? But it can be done, because much of what we often do in vaccine development is dead space. We do an initial trial, we wait a while to look at the results, then we do another trial to refine that some more. Then we decide, we spend some time deciding, well, is it really worth moving into a phase 3 trial, comparing it to either placebo or another vaccine? That dead space time can take years, actually. And this for these vaccines, we didn't have that dead space time. We moved from one phase right into the other. We didn't wait for the end to scale up manufacturing. The manufacturing went along hand in hand, and the processes got refined. So there were no corners cut here. And I think the one piece that we're trying to be very transparent about that we can't fix, because we can't warp time, is that we can't get 6 months of follow-up data on the whole cohort without waiting that period. And that's why we have these extra safety measures in place to look at things. But we would do that, by the way, for any vaccine after it's launched. But I think we can feel comfortable that all of the things were checked here that needed to be. And I feel very confident that these vaccines have had the right eyes on them. And in fact, compared to an average vaccine that goes through this process, there have been more senior eyes looking at these files than any other, at least since I've been at the agency.
Peter, can I add something that I think folks also don't understand? One of the reasons these vaccines became so quickly is because scientists had been working for years on the platforms that are the foundations of these vaccines. So I'm going to hand it back to you to explain that, Peter, because I think that's also something that's really misunderstood.
Mhm.
Right. So there were two fortuitous things that came together. There's a platform called the mRNA platform that was used for these vaccines, is one that had been studied a bunch for other infectious diseases. Now, it had never been used to take a vaccine all the way through to approval, but it was there ready, and the scientists at the National Institutes of Health jumped on it and were able to actually have a vaccine candidate really early on. And so what normally would have taken months and months and months or even years was done within a month. And then it moved very quickly from there. So by having this platform that was able to be used, and that will probably serve us well if we need to in the future use it, it allowed us to have a jump start on getting these vaccines. So we didn't have to start from square one. We started from a platform that was able to be taken advantage of very early on.
Well, that's great. Thank you. So now we know how we got here. So let's look into the future. An NEA member named Angela asks, how long will the vaccine immunity last? And first, and also maybe you can address how long does it take for the vaccine to take effect, and how effective are these vaccines? Is this a one-time thing, or are we going to have to get an annual shot like with the flu?
Well, Angela just asked, I'm going to give her, she's going to get her money's worth for asking that question, because there are a lot of answers to give there. So I think and I may pass it off to Nancy after this, but just to start, we know that after your first vaccine, probably starting about 14 days after, you're somewhere protected by, whether it's 30, 40, 50%, you're already getting some protection against COVID-19. And we know that probably after, just before you get your second vaccine, that may be up at, it's probably rising. When you get the second vaccine, though, you get the full, you get towards the full extent of immunity within a week or two after that. Okay. Now, there are some mysteries yet that we don't know. And one is we don't know how long that immunity will last. We know it's at least it's a number of months, but we have to follow people out, because that was as the part I mentioned. We couldn't warp time. We don't know how many people will be fully immune a year out, and we're going to have to follow that. So we still are not sure whether people will need booster shots a year out or at some period in the future. Additionally, we don't know the full set of variants that this might prevent, but we know, at least for the one of the questions that often comes up is that UK variant and the South African variants that have come up. Are these vaccines going to prevent or protect against them? And at least the good news is people have looked already, and it looks like these vaccines will protect against them. So that's good news. So I think there's some things we just don't know. Now, some people could say, well, I need to know how long it's going to protect against before I can decide to get the vaccine. I would say, look, we're in such a deep hole right now. As long as it protects for 6 months or more, that's going to help get us out of this hole. And if we need to be revaccinated, it may be the case, but we just don't know yet.
And the only thing I would just add to that is that, again, while we often think about what we don't know, what we do know is that we've got this vaccine that is 95% or so efficacious.
Yes.
And, back in the summer, we were thinking if it was 50% effective, 70%, we would have been on top of the moon. So, I mean, I just think we have to keep reminding ourselves of what good news this is. And then, understand that there's going to be more information coming out, because this is still a new disease.
Well, let's do one more sort of science question around the vaccine itself. And an SEIU member named Eva asked this question about can you talk about the adverse effects? What do we know about them so far?
So Eva, I can start, and then probably Nancy can continue on this one. So we know there were certain things that were seen in clinical trials that are not uncommon. There's local discomfort where you get the vaccine, and that seems to be somewhat more with the second dose than after the first dose. We know that a fair number of people get some mild symptoms of feeling a little flu-like, achy joint aches or muscle aches, or might have a headache or even a slight fever for a day or so after the vaccine. In terms of more serious things, there were not that many more serious ones until after actually the vaccine was actually deployed. You may have heard that there were these allergic reactions, and the allergic reactions are something that the Centers for Disease Control and FDA have been watching very closely. They're pretty infrequent, but obviously serious allergic reactions are scary things to contemplate. They're happening right now, and Nancy can probably say more, Dr. Messonnier can say more, but probably happening on the order of about 1 in 100,000, give or take a little bit, vaccinations. And that's why we're actually making sure that any place that's giving these vaccines is ready to be able to treat those allergic reactions. But in terms of other major side effects, there have not been. I think something that you may have read about, just by the way of complete transparency, or this question of whether there's an increased risk of Bell's palsy, which is something that can, a neurologic syndrome that can affect the face. And that we just don't know yet. We just don't have enough information to know whether that's an effect of the vaccine or not. One of the problems when you give a vaccine to many, many, many people all at once is that you see things happen. And you have to figure out whether those things that happen are related to giving the vaccine or relating to life in general. It's some things we pick up, we have to figure out what would this have happened anyway without the vaccine. And so we're still doing a lot of that. And that's the job of some pretty good epidemiologists at CDC and FDA to try to sort that out.
Maybe
Nancy, I don't
just
know
to
whether
add-
you want to add anything there.
Yeah, maybe just to add a little perspective. I think one thing that's really different in vaccines than in medications is when you take a medication, you take it because you're sick. When you take a vaccine, you take it to prevent yourself from getting sick. And so when Dr. Marks and I think about vaccines, it actually is safety first, even before you think about effectiveness. And therefore, safety is frankly always top of our mind as we think about any new vaccine candidate, and especially this one. So we've been extra diligent to make sure that we have robust systems, but also that we have people looking over our shoulders, looking at the data to make sure that we're doing everything we can. I'd rather vaccines didn't have any side effects, right? One thing for you all in your jobs is that there are a proportion of people in the first rollout of this vaccine who say they didn't feel well the first day. And so, for example, we've said to hospitals, gee, you probably shouldn't vaccinate everybody on the COVID ward on the exact same day, because if they're all sick the next day, or if a substantial number of them are not feeling well the next day, you might be short-staffed. And I would say for those of you in other industries, as you think about vaccination, you might want to think about that too. I would presume that for firefighters, you wouldn't want to vaccinate every firefighter in the same house the same day, because if a substantial portion of people didn't feel well the next day, you'd have a problem. The side effects do seem in the clinical trials to be worse on the second dose. It's something we're following closely. The severe allergic reactions are more common than we see in routine vaccinations, but it's still really rare. And while, again, I would rather we not have any side effects, this is something that we actually know how to treat, and that regular clinicians should know how to treat. And so we're making sure that the folks administering the vaccines have the necessary equipment, that they know what the protocols are. And so far, these patients have gotten access to care quickly and have actually been doing okay. So recovering really actually pretty quickly. So again, not what we want to see, any adverse events, but we do feel like what we've found so far is something that actually can be managed by the clinical sites that are administering the vaccine.
Maybe I can just, I want to just, I don't mean to be a mind reader, but I just want to add a couple of things, questions that often come up about the vaccines, because there are some social media stories that let's just deal with them right up front. So this vaccine does not cause sterility. Someone got some crazy idea that because there were a few nucleotides similar to some protein that similar to the message for a certain protein, that it could have some effect. There's no evidence whatsoever. And in fact, evidence quite to the contrary from animal studies, that there is no effect on reproduction. So that's not an issue. There's also been, it's going to get incorporated into your DNA. This genetic material is going to get into your genetic material. That's just not going to happen. This is ribonucleic acid, which doesn't get into the nucleus of the cell to begin with. Even if it got into the nucleus of the cell, for it to get into your DNA, it would need an enzyme that's not there, called reverse transcriptase. So that's not an issue. The vaccine, when given, leads to the expression, it leads to the production of a protein on the surface of the cells that is relatively rapidly degraded after the immune system is tickled by it. And probably within a day or two after getting the vaccine, you actually don't have very much, if any, of hints of the vaccine itself left. What you have is the immune system, which has been tickled by the vaccine, doing its thing. And And then the final one is there are no nanobots in the vaccine. We are at the FDA, our first job that was, we were told to do in 1902 with the Biologics Control Act of 1902 was to make sure that vaccines were pure. I can assure you that there are no nanobots in our vaccines. Sorry, I had to be a little lighthearted there.
That's great. So listen, let's move from sort of the vaccine itself to how we're going to get out there and getting it to different populations and into their arms, as Dr. Gale showed us. So we're hearing that some states are readjusting and compressing priority groups to speed vaccination. And there are reports that this would allow states to move to lower priority groups before finishing higher priority groups. And if this is the case, who's going to make sure that serious outreach and commitment to vaccinating populations that have been hit the hardest and are at greatest risk, are completed? On this call are plenty of hospital workers, nurses and nursing home workers, blue collar workers in hospitals who do janitorial work and messengers, but also home healthcare workers and teachers and other people who may not be at the very front of the line, but clearly are at risk because they go out every day and they're seeing the public and they're making sure, all the public functions, correctional officers, where are all these groups enlisted? How are we going to make sure that these workers who are maybe outside of hospitals and not 65, but still at great risk, how are we going to make sure that they're near the front of the line?
I presume that was to me.
I'll let everybody answer, but why don't you start?
Yeah, so again, I just want to say that this is going to be hard. It's great to have a vaccine and a safe and effective vaccine. It's essential to have that. But if you don't get vaccines into the arms of people, and if your goal isn't protecting people, then what's the use of the vaccine? A vaccine that sits on the shelf is not effective for anybody. And so our goal at CDC and at FDA has always been to use this vaccine to stop the pandemic. I think that's what we all want, and to protect people. The initial rollout in these first weeks and months are going to be complicated. There are limited supplies of vaccine. And frankly, we're doing something that as a country we've never tried to do before, which is push out these vaccines in a very short time span to the entire country all at once. And if life wasn't complicated enough, the initial vaccine rollout was during Christmas. And these vaccines, while not questioning their safety or effectiveness, are more complicated than a lot of the vaccines that we use for routine immunization in the US. For example, compared to a flu vaccine, these vaccines are more complicated because of how they're packaged and how they're stored and how they're delivered. They need to be kept in cold chain. That is, they need to be kept at temperatures that are not available in every doctor's office. They are in multi-dose vials, and they're stored in ways that once you defrost one of the vaccines, you have to use it really quickly. And so it makes the operational complexity really difficult. And add on to that, we're trying to do it while socially distanced. So all those things aside, I would say, I feel like the initial rollout has, within reason, gone pretty well. But frankly, that was easier than where we are going. Most people agreed on the first list. Long-term care facility staff, because of the fact how hard hit they have been by the pandemic, and healthcare workers, because they are the heroes that we need to take care of sick patients every day. But as you move past those groups, there are a lot of other groups that frankly can easily convince me that they should be first in line compared to others. And there's only so much vaccine. And so I think this is where it gets hard. And this is where the principles that Dr. Gale talked about are so important to me, that we need to not just get vaccine to people who are like me, rolling up their sleeve right away. We need to make sure that people who need a little extra time, who need a little extra information, aren't kept from getting the vaccine, and that they have access to that. What I can say for all of you is that I hope that you're working through your health departments and through your communities. That's how we're going to get vaccine into every corner of the community. And, I think that for folks that are in these really essential worker groups, You should be working with your health department now to say, okay, how can we help you stand up vaccination efficiently to get all of our workforce vaccinated? And so the most that you can do to actually make it easier for the health department by organizing yourselves, I think that would really help. You know, health departments have been really struggling to deal with all the everyday efforts on top of trying to control a pandemic and do contact tracing and all the other things that they've been trying to do all year. And I think that the organizational skills that you all have and your help in getting the messages out and figuring out how to efficiently vaccinate your communities, that kind of help would be appreciated. Dr. Gale?
Yeah, I was just, sorry, I was just going to add, and you didn't say it yourself, but you know, CDC has such a huge role to play at a national level in terms of kind of setting the standards and actually, you know, for some of the accountability. And you know, CDC always has worked and just, you know, does work through the state health department, state territorial health departments, but it really is, you know, CDC is the national leader in this. And, you know, I think with the commitment that CDC has made from the very beginning to have this be an equitable rollout and to really think about how to develop the data systems to make sure that we are able to keep track of things, you know, so I think that national leadership is such a critical piece. And, you know, I think we will see more of that moving forward. I also just, you know, I think we have to remind ourselves that we are early in this and that in a few months we may have more vaccines and we may have more options and we may have vaccines that will be easier to administer and that can be administered in a more distributed way than the ones now. So you know, I just I think we have to keep reminding ourselves that as urgent as this is and as important it is to get this first piece of the rollout right. It is hard. It isn't something that we have done at this scale before, but we are early in it. And I think that there's going to continue to be broader and broader options and different ways of doing this that will allow us to have the results that we want.
Thank you. Dr. Gale, let me follow up with you on that because this is really an important issue. You know, we've all seen the statistics that at every age, members of communities of color are at far greater risk of serious illness and death. A lot of that's because people are essential workers. They're going to work and they're, you know, they can't stay home. Black workers, Hispanic workers are all, you know, their job doesn't allow them to work from home. So they're out there, they're being exposed and they're at greatly increased risk. So have there been concerns so far about the inequitable distribution of vaccines, and what should go into a state distribution program now as they're being set up to ensure that racial inequities in distribution don't occur?
Well, you know, I think that's why the frameworks that were developed took that into consideration so that in fact, as this rolls out, and we all want this to roll out as rapidly as possible and have these phase one roll into phase two, roll into phase three, and roll into phase four as rapidly as possible. But I think it is important to keep in mind that frameworks were developed so that there would be some equity as a part of it, and people wouldn't be jumping the line because they have resources or greater access. I mean, just like all three of us who probably could jump the line have said, we believe that the integrity of this means we should wait until it is our turn. I think it's an example. So I just think that is a critical, important part of this. I also think sometimes people forget that, while we talk about categories like healthcare workers and people automatically think about doctors. Well, no, as we've said several times, we're talking about people who are often on the front lines who do come from these communities. And I think we have to recognize that across these different phases, equity was built into those, and people fit into multiple buckets. You're not just a healthcare worker. You may be a 65-year-old African-American woman with diabetes. So, I think we have to realize that these categories, if you will, are also, there's a lot of intersectionality between those. And I think as everybody tried to look into them, equity was embedded into them.
Well, thank you. No, and by the way, I was on that panel with Dr. Gale, and with her leadership, I think we really did address these issues. And if you're interested in pursuing this further, that report is available on the web at no cost.
And I would just say, you know, you made a huge contribution about thinking about the workers and you know, the community that is with us today. How do we make sure that we're thinking about equity as we look at the categories of people who keep our society functioning?
Well, thank you. So, you know, two of the unions on this call represent millions of teachers across the country, and they're all wondering about how vaccines are going to impact what goes on in schools. And, you know, children have not been approved for the vaccine. So even when teachers get vaccinated, how will this affect what goes on in school? So if anyone has any thoughts on sort of the vaccine and reopening schools and protecting teachers, and also making sure that kids don't get sick and bring the COVID back home to their homes, you know, what should be done, and how is this all going to work?
Well, maybe I can give you a start by the beginning piece of getting the data that we need to be able to vaccinate children, and where we're likely to be. Probably within the next very few months, we'll start to know about the vaccine in older children. So the 12 to 15 age range, we're already starting to see the vaccines are just poised to move into trials in those populations. And the good news there is we don't have to do the same type of big outcome trials. We just need to make sure that they're safe and they give an immune response. And then once we know that they're okay in that population, we'll age de-escalate into a younger population of children, somewhere from about age 7 to 12, and then down from there. And that way, hopefully, as we start to come towards next fall, we'll be having the kind of information we need to start to vaccinate children of all ages. Now, that does mean that we may not be ready with vaccination of all of the children by then, but then the hope is, by a combination of measures, including having teachers vaccinated and using appropriate social distancing, et cetera, that we'll begin to be able to get life back more towards normal for children come the fall. At least that's what I'm not the expert in this, but that's where at least some of the vision is headed, because I think it might be a tall order to think we're going to get everyone vaccinated by fall.
So let's ask then Dr. Messonnier and Dr. Gale, let's assume even that the teachers do get vaccinated. You know, what does that change in schools?
I know that many state health departments have actually prioritized vaccinating teachers in a desire to get kids back to physical school. And I can say that I have 2 teenagers, and they have been home struggling to educate from home since the spring. And I am, you know, it is top of my mind to try to get them back to school, because I think that their educational experience will be better, and because I understand that many other values of being in school. And I want to make sure that teachers get the information that they need first and foremost to feel good about getting vaccinated. So I hope that meetings like this can help answer questions about the safety and effectiveness. But the second question of what you're asking is really the layering of protections. And that's something that CDC is looking at. You know, the question is, if, for example, you're vaccinated, would you then be protected not only from getting disease, but also from transmitting it to others? And if so, you might not need to wear a mask. I don't think the science is there yet. There is some preliminary data from some studies suggesting that. But for now, even if you're vaccinated, we are going to still expect that you're going to need to wear a mask, and you are going to need to be socially distanced. But that's something that we're going to be looking at really closely as not only individuals get vaccinated, but as communities get vaccinated. I think for a while longer, we're going to want folks to abide by social distancing, but think of it as layers of protection, and that if you layer the vaccine with social distancing, we're hoping that provides an environment not only that that keeps teachers safe, but that makes teachers and families feel safe for kids to go back to school.
Great, thank you. So let's go to a different set of questions. We had some questions about herd immunity. And maybe we'll go back to Dr. Gale first, say if you could tell us a little bit about that. And do we know what percentage of the population needs to be vaccinated in order for the public space to be safe for the aging population? That comes from an SEIU member, or the others if they want to answer that as well. But
yeah, I mean, I've just started, and I know others will have things to add as well. You know, this whole notion of herd immunity is around how do you think about a population being a high enough proportion of the population being immune to an infection such that you basically have population protection, and that you have slowed down the transmission enough, and it becomes very, very unlikely that there will be any major transmission going on. And I think, again, because this is still a new disease, we don't have an exact sense of what will it take for herd immunity. For something like measles, for instance, which is very contagious, it's what, 95%, I guess, to have what we feel comfortable in terms of herd immunity. So 95% of the pediatric population immunized to make sure that we basically have a population level impact of not continuing transmission. I think the estimates based on the infectivity is somewhere higher than 70%, probably more like 80 to 90%. But others may have more depth to it. But I think it really, again, is one of these areas where we're still, there's modeling, but then we still need to have more experience with this. And, as Dr. Mark said earlier, there's going to be this mix of natural immunity, and then that we also don't know how long it lasts, as well as the vaccine immunity that we also don't know how long it lasts. And so that complicates as well. So
I go ahead, Nancy.
And that I think something people misunderstand is herd immunity is not a national number, right? And so when Dr. Gale says 70, 80%, she means 70 to 80% in every community, not one state has 100% and another state has 50%. And so it really still means that the vaccine, we have to get it everywhere. And frankly, our goal is to get everybody vaccinated because we don't know what that number is. And wouldn't it be a tragedy if we were a few percentage points short? Peter?
Yeah, no, I actually suspect that if we have, just looking ahead into the crystal ball into what's ahead for us, we're not going to know exactly where herd immunity is. But what we probably will get to a point is that we'll start to see, once we get enough people vaccinated, the number of new infections starting to decline. And eventually they're going to get to a place where we're going to be able to contact trace again. And as opposed to before, when we were contact tracing and all you could do is have someone isolate, we'll be able to contact trace and vaccinate. And so if people were not vaccinated. So I think we're going to be in a place that we probably won't know the exact number. We won't know there till we won't get there till we get there. But it's probably, I think we all agree it's probably somewhere, is it 70 to 80? It's somewhere up there. And exactly as Dr. Messonnier said, that it's going to have to be across the country. And my guess is the pandemic will end kind of will gradually, probably, it's not going to be like we're going to wake up one day, someone's going to declare, we're at 85%. Now we can take off our masks and all go out to the movies together. Although I'd love it if I had a magic wand to make that happen. What's probably going to happen is we're going to have a gradual progression back towards normal life. And it will allow us, we'll probably understand what that percentage is as we get there. It may be different parts of the world that are a little ahead of us will understand what that percentage is smaller, my guess is that there may be island nations that will get there sooner, perhaps because of smaller populations, easier to, and we may get a sense of what that percentage is. But it is going to be, it's going to be a little while longer that we're going to be doing our mask wearing, hand washing, and social distancing.
Great, thank you. So here's a question that came in multiple times. I'll give you the one that came in from an NEA member named Jen. How does the vaccine affect pregnant, soon to be pregnant, and breastfeeding mothers? And a related question from an AFSCME member, is there any reason why someone should not get the COVID-19 vaccine?
Well, the only reason why someone wouldn't want to get the COVID-19 vaccine, that I can think the only absolute contraindication is if they are known to have an allergy to any one of the vaccine components. That would be a reason not to get the vaccine. And probably we wouldn't recommend someone with active COVID-19, someone's actually sick, getting the vaccine as well. But that's more of a relative recommendation. And in terms of pregnancy, we don't have a large amount of data. And in fact, it's the Centers for Disease Control and Prevention that's getting a pregnancy registry right now that's actually getting added to very vigorously by the day. But from our perspective at FDA, knowing what we know about these vaccines, about the toxicology, and about what we know about animal studies, we're very comfortable having women have conversations with their doctors about the benefits and risks of taking these vaccines. Right now, many women who are pregnant or about to become pregnant feel that the risks are far outweighed by the benefits of not getting COVID-19, which could be very bad when one is pregnant. So it's an individual discussion until we have more systematic data. But at least from the FDA perspective, it's not an unreasonable thing for a pregnant woman to have that conversation and decide to get vaccinated. And everyone wants to add anything else to that?
I'm going to we're soon to be wrapping up. Go ahead. Go ahead, Helene, I'm sorry.
Oh, no, I was just going to say, only to say, I mean, part of why there's not a lot of data is that pregnant women as a group weren't included, but people got pregnant while they were in the trials. And so there's evidence about pregnant women, right, kind of retrospectively, because they got pregnant in the context of the trial.
Exactly. And there was no evidence in this. It's just too small numbers to make a lot of statement about the few dozen women who got pregnant while on the trial, but there was no obvious adverse effect in those individuals.
Great. So I think, we're going to wrap this up. I'm just going to add here that, I think we're very fortunate that the unions involved really are on, while the members are on the front line of treating this pandemic, the unions are on the front lines advocating for policies to make sure that all of you and your families are protected. When we talk about the world of schools, we're talking about protecting not just teachers, but all the employees in the school, the school bus drivers, because all of them are there need to be functioning. When we talk about hospitals and nursing homes, it's not just the doctors and the nurses, but it's every worker there who plays a role. And one thing this pandemic has done is it has illuminated for the country the importance of every worker, and not just the high-paid professional workers, but these institutions that are so important to taking care of our elderly, our patients, getting food on our table, making sure our transportation systems run. They all are operated by people, many of whom are underpaid and right now are overworked, and they're doing heroic jobs. And I think we're fortunate. Your unions now are fighting to make sure you get the vaccines you need, but also to make sure that the protections are in place, because vaccines alone are not going to protect us. And so I'm really happy to have participated in this session. So I'm going to turn it over, see if our three very distinguished panelists would like any final words before we close it out.
My only final word, and I would just add my thanks to everybody, both on the panel, but also those who do what you do every day. You mentioned, the fact that these are groups that are also powerful for advocacy. So I would just leave one message, is that I do hope that we will continue to advocate for adequate resources to be able to execute this over this next year or so. Having worked for the CDC for 20 years, CDC and public health infrastructure is always underfunded. And I do think that it is going to take adequate resources to do this well. So to the extent that you can use your voices to make sure that, given the billions of dollars of investment that we have made to getting the vaccine, that we also make the equivalent investment to making sure that people get vaccinated. So that would be my only plea.
But I will just say that I appreciate the opportunity to talk to you all again, and I appreciate folks tuning in around their dinner hour to listen to us. I am fully appreciative of all the things that you all have done this year and all the things that I barely understand that you've done this year to keep our society moving. Like you, my counterparts at FDA and a huge number of staff at CDC have spent the year trying to combat this pandemic, every day trying to do the right thing. I believe that this vaccine is safe and effective. I believe that it is the tool that will help us end the pandemic with continued social distancing and mask wearing. But I also ask that you understand that it is not all going to go perfectly. There are going to be bumps in the road. We're human. We will try our hardest every day. And I know that our state and local health department partners will too. But there are going to be things that don't work perfectly. And I hope that you will also exercise some patience with the system as we try to do something really unprecedented. But understand that we only can do it if we're all together, pulling together, working towards a common goal. I really think that that's the way that we're going to end this pandemic together.
Yeah, maybe I can just pick up where Nancy, I just think that this has been a marathon for all of us this past year, a marathon that has been challenging to get through. I think the vaccine is something that brings us hope now as we have something to think of. But ultimately, I think we all are going to have to take care of each other. And I know that's what all of you do every day. You take care of each other, you take care of us. But we have to really spend this time taking care of each other, helping us through these coming months. The vaccine's here. I think it's a hopeful message, but we're still going to have to work through these coming months as we work to come out on the other side. So thank you for all that you do, and take good care of yourselves and your loved ones.
Thank you. And please join me from your homes, from your workplaces, thanking Dr. Gale, Dr. Messonnier, Dr. Marks. They really are national heroes. So good luck, stay safe, take care.